Thanks, Kimberly. Yes, good morning, all. I am Mariah. I am with the Colorado Health Institute, and I will be facilitating today's meeting, which is the Alternative Payment Model 1 for Primary Care, APM 1. And this is our first community forum. And I will be joined today by Ashley Brown and Kimberly Fu, my teammates at Colorado Health Institute, as well as Zoe Pincus, the Quality Health Improvement Specialist at HCPF, and Dr. Peter Walsh, the Chief Medical Officer at HCPF as well. All right. Just to review today's agenda, we're going to first be going over the history and overview of APM 1. Then we're going to be reviewing the program performance and accomplishments. Dr. Walsh will be going over the APM 1 legacy. And then we'll have some time for open discussion. Open discussion, there will be ways to participate. Those ways are comments and questions verbally, or you can share them in the chat. When you are sharing those comments or questions, could you please make sure that you provide your name, organization, and disclose any financial interest if that's appropriate. And then if you do want to comment verbally, please be sure to raise your hand, the raise hand function in Zoom, and then you'll be invited to speak one at a time. All right. Oh, and one other thing, today's meeting will be recorded and we will be posting it on the APM 1 website. And let's see, another piece before we get started. We love feedback in general, and we would love to have some written feedback as well following the meeting. If you didn't get a chance to share, please, you can submit that information over to focus groups at coloradohealthinstitute.org no later than Tuesday, October 10th. And then there will also be an option at the end, potentially even now, that you can, oh, I'm sorry, just joking. We're going to keep moving on. I was thinking we had another way to send information, but please send it to the focus group at coloradohealthinstitute.org. And now, just a brief overview of we're going to be passing it over to Zoe to begin this meeting with an overview of APM 1.
Thanks, Mariah. If you want to go to the next slide, we can go ahead and review some slides that are probably familiar to a lot of people on this call. However, just to refresh everyone, in state fiscal year 2017-2018, the Colorado General Assembly authorized HCPF through a budget request to invest over $50 million in primary care each year on the condition that it be paid through a value-based payment structure. And APM 1 is how HCPF allocates that investment. And the per year investment shifts annually as it is subject to caseloads and the Joint Budget Committee's appropriated reimbursement rates. Historically, the pool of funds has been distributed evenly each year to all providers as an enhanced fee for service rate at 104% of the Medicaid fee schedule. Starting with program year 2021, we moved towards distribution based on provider performance. So providers with a quality score less than 200 points saw a reduction in their fee for service reimbursement rate, and that was redistributed to providers who earned greater than 200 points on their quality measures. Next slide, Mariah. The APM 1 program is part of the department's movement towards innovative healthcare delivery and reform models. The program seeks to accomplish 3 goals: provide long-term sustainable investments into primary care, reward performance for positive outcomes for primary care medical providers, while also holding providers accountable, and align with other payment reform programs to bolster shared outcomes. And now, probably move ahead 2 slides, Mariah. We're going to talk about some of our performance over the last couple years. So primary care providers have spent the last few years building out process for quality reporting and moving toward outcome-based quality measures. Program year 2022 was the second year we have changed fee for service payments based on quality measure performance. And 2022 was also the first year we implemented 3 mandatory quality measures for adults and 3 for pediatrics. And in the next few slides, we'll take a closer look at some performance trends over time on a subset of the mandatory quality measures that HCPF chose. Sorry, Mariah, do you want to go back one? We're going to do just an overview of program 2022 performance. So 87% of primary care medical providers who participated in the program in 2022 were above the 200-point threshold. 119 of those were between 200 and 250 points. 149 were between 250 and 300 points, and 8 had greater than 300 points. But there were also PCMPs who were below the 200-point threshold. 42 of those practices had fewer than 200 points. Some facts about those providers who were below the 200-point threshold: about 5 of those practices are practices that have chosen really not to engage with the program historically and were assigned default quality measures by the department. 5 of those of the total are located in a rural county, and the average member attribution was about 1,900 per practice. 10 of the practices had fewer than 1,000 attributed members. 20 PCMPs were between 1,000 and 2,000 attributed members. 10 were between 2,000 and 7,000 attributed members, and 2 were greater than 13,000 attributed members. So varies widely. Practice size varied widely in performance. Now we can get into some more specific performance over time trends. So the first measure we're going to look at is well visits in the first 15 months. So the first part of this measure, you'll notice there's been an upward trend from 2020 to 2022. The department goal for this measure through 2022 was 80%, which was in line with EPSDT standards. The national average for this measure was 57%. So APM practices in 2022 were at 68%. So that's great. We were above the national average. I'm going to go to the next part of this measure, Mariah. This is well visits in between 15 to 30 months. And the national average for this measure was 67%, and the department average was 63%. But overall, a nice upward trend from 2020. This is the childhood immunization status combo 10 ECQM version of the measure. You'll notice there are 2 separate dotted lines since the goal was increased between 2021 and 2022. But performance has remained similar across the years with a slight decrease from 2021. The national average is 39% for this measure. So we're still doing slightly better at 43%, which is great. And this is the administrative version of the Combo 10 measure. There's been a steady decrease in performance on this measure, however, since 2020, which you can note here. The department goal for this measure has also decreased. And the national average for this measure is 32%. And the HCPF average is about 41%. So still doing better than average, which is awesome. This is the diabetes hemoglobin test, diabetes carrier hemoglobin testing administrative measure that has remained similar, performance has remained similar from 2021 to 2022. This measure was retired in September of 2022. So unfortunately, we don't have national benchmark data to compare our department performance to. But the HCPF average was 79%. This was also a new measure in 2021, so that is why you don't see a data point for 2020. This is controlling high blood pressure. It's an electronic clinical quality measure. We have seen a slight positive increase in performance from 2020 to 2022. The national average is 62%, which we are above at about 68%. This is screening for depression, the electronic clinical quality measure version of the measure. We've seen a slight increase between 2020 and 2022 by about 10%. The national average is 40%, and HCPF average in 2022 was about 37%. This is the diabetes hemoglobin A1C poor control ECQM measure. We've seen a slight decrease between 2021 and 2022, which is actually good. This is an inverse measure, so a lower performance rate is better. The national average for this measure is 46%, and we are doing better than the national average at 34%. And then the last measure we're going to look at today is depression screening, the administrative version. Unfortunately, the administrative version of this measure is not a HEDIS measure, and so I don't have national averages to share. But the HCPF average was about 25% in 2022. And we've seen a nice positive increase in performance from 2021 to 2022. The measure specifications for this measure changed between 2020 and 2021, which is why you kind of see that like decrease from 2020 to 2021. And I will pause here for any questions, feedback, comments, before we kind of move on to the next segment of our presentation. Okay, well, we can always come back to questions at the end of the presentation. So if we want to move forward, Mariah, and talk about the APM1 legacy, I will pass it over to Pete.
All right, then, can we move on to the next slide, please? What I'd like to do is spend just a few minutes talking about how APM1, what we've accomplished in it, as well as how it relates to our future APM work. First of all, as APM1 will be ending, the date that it'll actually occur is still basically being determined. It'll be dependent upon the progress we make and the timeline that occurs with our current contract to, I'll say, improve our APM model, which is APM2. But key point here is the quality model that we've used in APM1 will serve as a foundation for the future program. There will be differences, but the lessons we've learned in APM1 will be applied in our future APM work. Next slide. So for this year, what's our glide path look like moving forward? There will be no changes to APM quality model for this upcoming program year. Again, we've learned a great deal in APM1. We realize there is some need for enhancement, But what we don't want to do is impose instability when in fact we know we need to make adjustments and we plan to implement them in our next, I'll say, iteration of APM. What we do encourage to occur, though, is that PCMPs should use this final year, likely final year, or nearly final year of APM 1 to continue building a foundation for quality reporting. So specifically, we encourage providers to become knowledgeable about what it takes to successfully get credit for doing the work they do in terms of the metrics that currently exist. Examples of additional work that could occur, for instance, include, for those not using ECQMs, would include coding the degree of hypertension control. There are codes for that. There are codes for hemoglobin A1C control, for instance. And finally, there are codes, for instance, for what the disposition is on individuals who receive depression screening regarding the follow-up plan. In addition, we encourage the providers to if they don't already have relationships, to utilize ECQMs to develop them and continue to work on reporting on them. And for those that already use ECQMs but are not currently passing through the supplemental data sets that allow us to essentially report on Medicaid level data, which we need to do as a department to CMS, or to understand the stratification with regard to race and ethnicity, we would encourage them to look into that and support that. We very much do want the supplemental data set information for ECQMs to be passed through to Contexture so that we can thereby get that information and use it to calculate, measure performance. Next slide. Just to give you this slide, and I think it's 2 or 3 additional slides, are really meant to send one message, and that is that as we move forward, the department is trying to align its metric programs across programs. And so this shows essentially what our current state is for APM 1, how it relates to the Universal Foundation measure set that CMS has developed, how it relates to CMS core measures that apply to Medicaid, and finally how it relates to the projected, because rulemaking is just really in the initial process with DOI regarding the APM measure set that'll be applied to multiple payers in Colorado. And as you can see, there is significant alignment between those 4 programs, and I'll say the domains you see on the left regarding primary care access, as well as preventive care, acute and chronic condition care, behavioral health care, and experience of care. But a key message we want to send here is that we are very much working for alignment. Next slide. The next slide really looks again in terms of how these focus areas apply to some extent to the past, which is really where we're at, not where we're headed. So again, you've got APM 1, you've got our health equity plan, which has a subset of measures that is frankly larger than APM 1. You've got the ACC KPI program that's currently in effect, which is different than APM 1, but related to how we incentivize our RAISE, the BHIP program, which is focused on behavioral health, again, RAI focused, and the ACC performance pool. So you can see they're not completely aligned across those programs currently, but moving forward, our future APM program goal is for that to be aligned again with the DOI program, which is in turn are related to CMS core measures, our health equity plan, and the Universal Foundation. Next slide, please. Okay, so what are the big wins we've had from this program? We do believe that significant progress has been made in building the basis for quality reporting. And that we think practices have learned a great deal. And frankly, we've learned a great deal about how we understand what practice capabilities are, as well as making sure we accurately calculate and measure performance. What are our challenges? We do realize that moving forward, we do have to deal with the issue of how to get reliable data from practices that have a low number of Medicaid members and or a low sample size for a given measure. So that is an important consideration we're taking into consideration as we build I'll say our next APM iteration. And I guess the final point, which is not on the slide I'd like to make is, we realize there's a very significant desire for stability in our metric program. And so I'll just say that moving forward, we are the foundation, I'll say the universe of measures that we're interested in. This department is very much focused on the CMS core measures, which is a large number. It's over 50, I think approximately 56. There's a smaller subset that we are going to put at the center of our program, and that will be basically the Department of Insurance APM subset that comes out of the rulemaking, which will occur over the next 4 months with the Department of Insurance. That center core of measures, which are approximately 12 quality measures between adult and pediatrics, plus two CAPS types measures for adult and children. Those will form the center of our APM program moving forward. We expect them to remain relatively stable. They're on the CMS core measure set. They're on the universal measure set, and we intend to apply them with other department programs as well. So one of the things we've learned, I guess I'd say, is alignment is very much desired by providers, and we intend to focus on that moving forward. Zoe, I'll hand it back to you because I'm not actually sure who has the next slide.
It's me. Hi, everyone. Ashley Brown with the Colorado Health Institute. And those are our prepared remarks for you today. So we'd like to move into our open discussion and hear more from you about what questions you have about what we've shared already this morning, other things that you'd like to hear about. So we'll go to the next slide. Here are a few things that we'd really like to hear from you in particular. As Dr. Walsh mentioned, this quality model is really building the foundation for future programs, and we want to make sure that we're learning from what we've learned in APM 1 together. So we'd like to hear from you what has worked well with the APM 1 quality measure model that HCPF should consider in future programs. What should change about the quality model in these future programs? And what else did we learn from APM 1? We know that the quality model will live on in future programs, but are there other things that you would like to see carried on from APM 1 or things that you would like to see not carried on from APM 1? We want to hear it all. So I will open it up for questions. You can raise your hand to make questions verbally. You can also put questions and comments in the chat or the Q&A. We have many ways for you to participate. Who has our first question this morning? All right, we have a comment in the chat from Barbara Bishop that the new workbook created by Myers and Stoffer was a helpful tool this year. Barbara, do you want to come off mute and talk a little bit more about what you found helpful about that tool and what you'd like to see in future tools?
Absolutely, thank you. So I am from Ray 1 and I'm a clinical program manager with Ray 1. So I believe for my purpose of supporting our PCMPs in this program and making sure that we're tracking along with their successes or where their challenges are, just being able to plug in where their baseline is and see where their goal is super helpful. And that tool's been really, I know there's been some past iterations of that. And, you have to go through some of those hurdles in order to get the final product. And I think it's been super helpful. So I appreciate that a lot.
Great, thanks for sharing that. And I see a thumbs up from Pamela Bohm. So I think she agrees with you. Awesome.
if you don't mind, I'll continue.
keep
I was
going.
gonna say, changes in quality model and future programs, and I've talked to Zoe about this, and I believe this is already in the works somewhere behind the scenes, is really focusing on the pediatrics, the pediatric measures, and making it meaningful for our pediatric population. It's such an important population, and ensuring that we have metrics that are meeting the needs of those providers is going to be super helpful as well in this program and for those particular members.
Yeah, absolutely. Dr. Walsh, do you want to respond to that?
Well, we agree. I guess I'm going to kind of reiterate a few points I made because I think so. First of all, we agree that in whatever program, and the reason why I'm being somewhat circuitous regarding what the future holds is the whole point of the major contract we just cut that we're working with a vendor on is looking at our APM 1, APM 2 models and enhancing how they operate in the future. So I'm being somewhat circuitous because all things are not decided. But the one thing I do want to point out regarding quality metrics, because it comes up quite a bit, and what is meaningful and what is useful very much is in the eye of the beholder, just to be honest with you. And so, again, we've got the big universe of CMS core measures. F2s have a similar but not totally aligned list. You got the CMS issued universal foundation list, of which a subset apply to what I would call primary care. Some of them apply to other subsets as well. You've got our health equity plan, which includes, I'll say, multiple domains to include what falls in what I'll call traditional primary care or pediatrics. There's some additional behavioral health measures on that. There's some additional perinatal measures on that. So it's not strictly I'll say, primary care set. And most importantly, you got what's on the DOI list, because by statute, we were directed to collaborate with the DOI regarding the development of a list that would apply to multiple payers. And we saw that as a good thing as a department. And so at the very center of that, again, are 12 measures, 6 adults, 6 children that are related, or to 6 child that are related to, I'll say, quality versus, I'll say, patient or a member perception of the care they get. So just to be, I'll say, transparent, we're not going to throw that back up in the air. Now, there could be some potential change in the DOI rulemaking process, but those are core measures that are important, that cover, I'll say, measures that are directly in the primary care domain. What I will say, though, is regarding those measures, Zoe spoke to what our performance is currently, but we'll talk more about this next time. But I just want to be clear, when we're currently in this program paying on performance for I'll say, a provider's total panel, if they report on ECQMs. And moving forward, this is why the supplemental data set information is so important. We intend to pay on Medicaid member metric performance, okay? And so that's why for those who want to use ECQMs, it's important to get those supplemental data sets being provided, because if we don't get that, otherwise we can't utilize that information to link it with, I'll say, our metric reporting mechanism for CMS. So when you look at, you'll see again this next time, there's significant variability in terms of at an aggregate level. There might be, I'll say, on average on the practices where we do get ECQMs, I'll say practice versus our best calculation using claims data regarding how those measures look. But the fact is, those are based on a relatively small number of practices. So key point here is we intend to use, I'll say, the DOI list, which is aligned with what we would like anyway. Frankly, we're going to be very interested moving forward in paying for Medicaid member performance. So, so I don't know what your opinion was when you're talking about meaningful quality measures for pediatrics. We don't intend to deviate much off that DOI list, if any at all. So I hope that's good news to you. But hopefully you'll appreciate the alignment it'll provide to providers.
Thanks for that additional information, Dr. Walsh. And I'll put a plug in for the next session. If you're interested in learning more about that Medicaid only reporting that Dr. Walsh just mentioned, that is the topic of session 2 next week. So come back and join us again. All right, back to this session. We have a few questions in the Q&A, so I'll tee those up. One is about measures, so we'll stay on that theme for a minute. From Julie Reskin, why is patient experience not part of the health equity measures? Often patient experience is the key issue that turns marginalized populations away from healthcare. Dr. Walsh, correct me if I'm wrong, but I believe patient experience is included in the proposed DOI list. Do you want to say a little bit more about that?
That is correct. And anyone else on our team is free to comment as well. That is correct. And Julie, we agree with you. However, I would just say that the whole way we do, as you know, we're required by CMS to collect CAHPS data. We do it, and it is on the DOI list. But how it relates to the APM programs moving forward, we have a lot of work to do on that. And so what I guess I'm saying is I think the department would agree with you conceptually. However, operationalizing that using the current CAHPS measure is problematic. Example, and what I mean by that is you need a fairly large sample to collect enough responses to form any kind of statistically meaningful, I'll say, conclusion at a provider practice level. And we have had challenges with that, and I would be glad perhaps to talk with you more extensively about the details on that. But the short answer is conceptually we agree. Practically, when you talk about how to calculate that type of measure at the practice level using the current CAHPS tool, it has been problematic for the department. I'll also say that CMS, as well as the DOI, as well as us, there's another measure basically that uses the patient-centered questionnaire that I know CMS is actively considering. The DOI is considering for potential inclusion on the on future lists, and we're interested in as well because we agree with you. But it comes the biggest challenge occurs with small practices where so we frankly need a simpler questionnaire to be filled out. We need a different methodology to actually collect it. And so I agree, but we do not have, I'll say, a fully baked plan on how to do that yet. It's a good question.
We have thanks and a thumbs up from Julie. And thank you, Julie, for that question. It's a really important topic. All right, another measure question. Will future APM programs continue to allow measure selection to vary year over year, or will they be more fixed once initially selected? Dr. Walsh, I think that might be another one for you. Oh, Zoe,
Yeah.
do you want to?
I can try.
Go ahead,
and then
Zoe.
you can back me up. As the APM2 program is currently, the APM1 quality model is a part of it. So yes is maybe a quick answer, and that you'll still get to pick your own measures. I know there's lots of work going on with the contractor we have to improve APM2. So I can't tell you what like the long run quality model will be, 5 years from now, if it'll be a more fixed set of measures or if it'll be, more of a you get to choose. I do think in our pediatric program that we're working on, it's going to be a little bit more of a fixed list, but it is all the measures pediatricians are already working on that they choose for APM1. So it's just like a more refined list, but there's lots to I mean, if you have opinions on if we should have a more fixed list, or if you like being able to choose your own measures, we would love to know. But we do, we do plan to continue our alignment with CMS core measures, the Division of Insurance list, and health equity plan. So the measures themselves will be from those lists.
Thank you. And that question was from an anonymous participant in the Q&A, but if that person wants to come off mute and become unanonymous, become known, I guess is the right way to say that in English, please do, because we would love to hear if there's a preference between those two options to inform these future programs. Or if anyone else who didn't ask that question has a preference. I'll pause and see if anyone has more to add on that topic.
Ashley, can I put a plug in for, as we
Yes.
move forward on the new development work we're doing for, I'll say, the future APM work, there will be opportunities for input from all groups, to include those on this call. And so I agree with what Zoe said, that I'll say just the full future has not been determined yet. What I do think you've heard, though, again, is we're committed to not switching measures every year on the list for this program, because for a whole bunch of reasons. But I would encourage you to participate in that work on the, I'll say, the future model, and there'll be announcements coming from the department on how to do that.
Great. And spoiler, there will be a link in the chat at the end of this meeting to sign up for a newsletter from CHI to be on the list when those announcements come out. We send them through both the department and CHI distribution channels to try to make sure that everybody possible knows that these opportunities are available. So look out for that link at the end of this meeting. All right, we have another question in the Q&A about the Myers and Stauffer workbook. Russ Ebel wants to know if the Myers and Stauffer workbook referenced in the chat is the same as the 2023 APM guidebook referenced in the website, on the APM1 website. So do you know the answer to that question?
Yeah, so the guidebook on the website is, our general how-to, I guess, of APM and everything you need to know about the APM1 program. And the Myers and Stauffer workbook is how each provider selects their measures for the program year. The workbook I can't remember if it's on the website or not. But it is sent out to providers before the start of a program year. So you'll have a chance to fill out all of your measures. It's an Excel workbook that you'll download and plug in the measures you've chosen to work on for that year.
Great.
So they kind of go hand in hand.
All right. We also have a few comments in the Q&A that I want to raise for the group. I don't have a question, just a comment. The data being sent to Contexture QHN has been complicated as far as validating the data and ensuring the data is being received accurately. Wish this piece was easier. That comment is from Nina Marineo. And I have good news from you. We have Contexture and QHN actually joining the next session to talk about support that they can offer in making that easier. So that support is available, and we'll talk a little bit more about that in session 2. Thanks for teeing that up for us. The next comment is that Medicaid-only claims and supplemental has not been a tangible way to track performance for many or most organizations. I'm excited to hear there will be a report available for organizations, but I'm hesitant to know how timely it is to demonstrate performance and understand improvement. Most organizations have invested in ECQM reporting, which provides real-time performance, understanding, and improvement opportunities. I'll tune in next week good, because that's the topic for session 2. But I do not have the confidence that timely tracking for Medicaid only will be available. Zoe or Dr. Walsh, do you want to respond to that concern?
I think most of it we could talk through next week, Ashley, but the thing I would just say is this is a Medicaid APM program. And so we are committed at the department to essentially have the APM program based on APM level data performance. And so, and there are other reasons as well that relate to our ability to report on our core measures to CMS, like us receiving, being able to understand, I'll say ECQ and performance on Medicaid members. And so that, I mean, and we can talk through more details next week, but fundamentally, this is a Medicaid APM program. And so therefore, our obvious, I think, goal would be that when we're paying for quality measure performance, it'd be based on Medicaid member and not non-Medicaid members.
And I think just to piggyback on that, I think we are continuously working to try to get more actionable lifetime data to our providers. We understand, there's huge delays, and how do you fix something if you don't know it was going askew 6 months ago? So I do just want to say that is something we are continuously working on, and maybe with the next phase of APM, we'll have some better data sharing capabilities with our providers who participate.
Thanks, Zoe. And I think that has been a theme of our comments this morning. We're hearing a lot about the tools, the resources, the data availability, the things that practices need in order to successfully participate in these programs. That's definitely a lesson learned that the department will take back and be thinking about in future programs. We'd love to hear any other ideas about tools you wish you had, or tools that you have that aren't working so well that should be improved for future programs. Anything coming to mind for folks? All right. As Dr. Walsh pointed out, this is not your last chance to chime in. Each of these programs will have their own stakeholder engagement processes, and we're looking forward to kicking that off very soon. All right, we do still have a bit of time for any last questions or comments. If there aren't any, we'll close out and give everyone back a few minutes in their morning. Barb, come off mute.
Thank you very much. Thank you. Here, I'll turn my video on. I didn't do that before, so I apologize. I wanted to ask, I'm working a lot too with the prescriber tool, APM, that's through HCPF as well. And I'm excited to see what benefits our providers can get through that program. But are there any discussions yet on like future plans about maybe even molding that into this APM or creating one? It's as a program manager and a facilitator of these programs, just makes it easier if we can streamline programs and incentives and bundle them into one I guess program to ensure that all that information is there. I understand, especially if funding is a certain way, that it can't be, but I was just thinking, I wonder if there's a way to do that in the future.
Yeah, I think that's an important point, and I know Dr. Walsh is thinking about it. Okay.
Zoe may have a comment as well. I haven't been around specific conversations around the prescriber tool and how you would integrate that in this program. But again, I guess I'll stress that we are being really mindful about aligning, I'll say, our future APM with what we do in our accountable care program with regard to raise, which then leads to, I'll say, synchronization of things like what are currently KPIs, the key performance indicator, the behavioral health and improvement program, and the performance pool. We are thinking about how to align that work while at the same time recognize they have to be distinct programs, as I understand it, based on how we obtain approval for them. But I have not been around specific conversations around the prescriber tools specifically. Zoe, can you add anything?
I can try. I've been a part of some conversations around the prescriber tool. I mean, maybe it's a future goal to integrate it with APM. But the prescriber tool as a whole applies to like all providers in the state of Colorado, so not just primary care. Where, APM is a primary care model. So
Yeah.
I don't want to say it's never gonna happen, but I think for a little while they kind of have to remain separate since one is such a bigger group of providers and APM is kind of just a subset.
That makes sense. That makes sense. Just trying to streamline things as I make it easier, but yeah, sometimes it just can't mend in or, mold in there with that, but thought I'd ask.
One day, Barb.
It's always a good goal. And I know HCPF is working hard to increase alignment to the extent possible. Right. Any other questions, comments, thoughts? If not, I will hand it back to Mariah to give us some more information about upcoming sessions and other ways to get involved.
Awesome. Thank you, Ashley. And thanks everyone for all your questions and comments. We all appreciate that. So up next, as it was alluded to multiple times, we've got a couple different times for everyone for folks to participate. So we have our second community forum on October 11th at 7:30 to 9 a.m. And the topic that day is the deep dive into quality reporting. The registration link is in the chat. Kimberly just put it there. And then we also have the third community forum, and that will be on the 19th of October, again at the same time, doing a deep dive into health equity. And also the registration link is in the chat as well as on the website. So just check that out. We would love to have you to ask all the questions. Then some contact information. Please submit any feedback or thoughts on this meeting no later again than October 10th. We have Zoe's email here, which is zoe.pincus@state.colorado or state.co.us. And then you can also email me at CHI, which is the focus groups at coloradohealthinstitute.org. And then we also have an opportunity, as Ashley said earlier, to be a part of our contact list at CHI. Hopefully a link will go in the chat here in just a moment. You can sign up and you'll get lots and lots of information of all of the fun value-based payment information and work streams and work that's being done in the future. So please sign up for that if you're interested. And we would just like to say again, thank you. It's so important for everyone to be a part of this work. We learn from all of you. And I just want to say thank you for giving us your time this morning. And I will give time back. Potentially, Ashley, you have something to say before we leave? Yeah. Nope. Okay.
No,
Perfect.
just thank you, everyone. And we're looking forward to seeing you in session 2 next week.
Thank you, everyone.
Thank you.